Hello, I am Sue Adkins. I'm the Regional Core Center Specialist with the Great Lakes region, which is housed at HFM. And it's my pleasure to introduce Dr. Eric Mullins. He is a pediatric hematologist at the Cincinnati Children's Hemophilia Treatment Center. And in 2008, he founded the Young Women's with Bleeding Disorders Clinic. Yes, in 2008. He also does research besides taking care of patients. And in his free time, he likes to make barbecue, particularly two kinds. And he loves to hike in national parks. So we will be seeing a presentation by him. Please place your questions in the chat box. Dr. Mullins is with us right now, and he will be answering the questions after his video presentation. Take it away.
Good afternoon. My name is Eric Mullins, and I'm a hematologist at Cincinnati Children's Hospital Medical Center. And I'd like to thank you for joining me this afternoon to talk about new therapies for hemophilia and what's coming down the pipeline. We'll talk about a therapy that you're already familiar with and kind of why it's changing the paradigm or the model of hemophilia therapy. And then we'll talk about what else is new out there and what's coming into hemophilia therapy into clinical studies. And so these are my disclosures. So today we're going to be talking about several therapies that are essentially anything but factor VIII. So first of all, one that you're probably familiar with is called emicizumab. It goes by the trade name Hemlibra. And Hemlibra, of course, has been out on the market for a couple of years now, so many of you are familiar with it. You've used it. We'll talk a little bit about that and more information about emicizumab. Then we'll get into two non-factor therapies that are not emicizumab and that are still under clinical trials, fitusiran and anti-TFPI antibodies, and we'll talk more about what those are. And then at the last 10 or 15 minutes of the talk, we'll then spend some time talking about gene therapy. And there are gene therapy products that are in study. There's some that have the studies are ongoing. And this seems something like we tantalize people every few years, thinking that it's just around the corner and that we're going to have a product available pretty soon. But unfortunately, that hasn't been the case so far. Hopefully that is becoming more of a reality and not just something that we've been hoping for. So without further ado, we'll start talking about emicizumab. And of course, emicizumab is an antibody that has factor VIII-like activity. And so this is primarily for those with hemophilia A, or it's really only for those with hemophilia A, I should say. And so as I mentioned, emicizumab is an antibody. So what is an antibody? And we throw that term around a lot. You're hearing a lot about antibodies now with COVID and the vaccinations for COVID. And so what really is an antibody? Well, I kind of have a pictorial explanation here and words here, so you may pay attention to either side. But an antibody is a protein, and a protein that's made by one of our immune cells called plasma cells. And antibodies are made such that they are targeted toward a very specific target. And we call those antigens. You don't have to remember the fancy name for them. You can just say target. But you can see in this schematic, this antibody seems to be designed for only one of these, antigen A here, or target A. B or D or E is not going to sit down in that pocket very well. And that's really the case with antibodies, is that they're very well adapted to bind a single target, and they usually bind them very tightly. And usually, the purpose of antibodies and the reason we have them is that they help target that object for destruction. Usually, they're immune mediated. They help protect us against infection. And so, they may bind a foreign protein, they may bind a bacteria, they may bind a virus. But anyway, it helps clear that item for removal. Now, many of you are familiar with an antibody in another context in hemophilia, and that's factor VIII inhibitors. Those are antibodies that bind tightly to factor VIII, they neutralize them and then clear them. And that's really a fairly good example of what an antibody does. Emicizumab, though, is a next step in antibody development. It's something beyond just our standard antibody that binds and clears things. And one of the revolutions, or the kind of step forward with emicizumab, is that it not only binds just one thing, it actually was genetically engineered so that it would bind 2 different targets. So I'm going to go back to this other slide here for just a second. So if you imagine this one is binding A, but this one was designed to bind B. And so then you have a what we call a bispecific antibody, or an antibody that targets 2 different targets. And so in the case of Hemlibra, it binds factor IX and factor X. And these are clotting factors that factor IX, of course, is low in hemophilia B. And factor IX just doesn't work very well without factor VIII. And so that's why hemophilia A and hemophilia B look almost exactly alike from a symptom standpoint, is that, you don't have factor IX, so you don't have any activity in that way. If you don't have factor VIII, it's almost like not having factor IX. It just doesn't work very well. And so emicizumab is able to bind both of these factors and bring them close together. And so, as I mentioned, factor VIII improves the efficiency of factor IX, and emicizumab, to a degree, mirrors this activity. So it's not factor VIII, but it has factor VIII-like activity. And one of the other kind of clever ideas about emicizumab, or one of the advances, is that it's not a very good antibody. So remember, I said they usually bind a target very, very tightly, but emicizumab binds its target and then it's able to release it fairly easily. And so then those proteins can go about their job and go on and activate more other, go on and help form a blood clot, as opposed to being targeted, bound by emicizumab, and cleared. And so this is a kind of cartoon of what I just told you. In the top frames, we have factor IX by this little red Pac-Man guy, and factor X by the little blue guy who's not yet a Pac-Man. And factor VIII is kind of serving as a matchmaker here. It's bringing them together. It's kind of holding them, so to speak, and kind of bringing them together. Well, emicizumab, or Hemlibra, you can see now this is the antibody, kind of the same as I showed you at the beginning. And it's got one arm here that fits this red Pac-Man guy, and one arm that fits this blue guy, and it just brings them together, and like factor VIII, just kind of hugs them together and allows them to activate, and allows IX to activate 10 and then help with blood clotting. So so you can see that this is just by the simple act of bringing these 2 factors together, you're increasing IX activity and somewhat replacing factor VIII. So this went through many studies in mice and animals, followed by early studies in humans, and finally culminated in this study called Haven-1 was the official name for it, but it was published in the New England Journal of Medicine. Many of you know that's a very prestigious journal for medical studies, and emicizumab prophylaxis and hemophilia A with inhibitors. And so this was the study for adults that allowed licensure in the United States and in Europe. This was followed by what was called Haven-2, or a study of emicizumab in children with inhibitors. And in both of these situations, when you have an inhibitor, it binds factor VIII, but as you can imagine, that inhibitor doesn't recognize emicizumab, and so it doesn't care if emicizumab is there, and emicizumab doesn't care if the inhibitor is there. It works just as well if you have an inhibitor. So this was really a breakthrough therapy for people with inhibitors, and really could bring down significantly their bleeding. However, this was followed then by Haven-3, which was emicizumab prophylaxis in patients who have hemophilia without inhibitors. And so this really opened the door for almost everybody for everybody with hemophilia A, and has really changed the way many of us practice with regards to prophylaxis. And so many patients now are on emicizumab prophylaxis as opposed to factor VIII. I would say probably the minority of people in the United States are on factor VIII replacement at this point in time. And then one more Haven study that I'll finish with is that, so Haven or emicizumab was approved for every week dosing and every other week dosing. And this final study, Haven 4, well, it's not the final Haven study, but this study allowed for every 4-week dosing. So now you have a drug that you not only don't have to give IV, emicizumab is given subcutaneously like insulin, but it can be given every 4 weeks. So when you think about the dosing is the same regardless of inhibitor status. So it doesn't matter if you have an inhibitor or not, the dosing is the same. Emicizumab, now one of the other things about an antibody compared to factor, so factor, we had to dose, if you're thinking about a standard half-life product like Advate or Cogenate, you had to dose, often 3 times a week in order to prevent bleeding. With extended half-life products like a Lactate or a Dynavate or Jivi, you may be able to get away with twice-weekly dosing. Emicizumab, the antibody is a very long-lived protein, and so you don't have to dose it as frequently. You're able to give it subcutaneously as opposed to IV. But in order to get the levels up to levels that are therapeutic, we have to give what we call loading doses, which are bigger doses more frequently just to get the therapeutic level up. And so we give these 4 weekly loading doses, which are essentially double weekly doses. And then you can follow 3 options. You can either dose once a week, you can dose every other week, or you can dose every 4 weeks. And essentially, this is 1x. This is double that weekly dose. So this is 1.5 milligrams. This is 3 milligrams. And this is double this dose. So this is 6 milligrams per kilogram. And much as you remember the fluctuation of factor VIII levels with prophylaxis, as you go further between dosing, you do have a little more fluctuation in emicizumab blood levels. And so without getting into the specifics here, you can just see that if you're on weekly, you have a lot less variation in that level, and a lot less white space up here at the top and bottom. And the purple area here is just defined as kind of the deviation from the average. So where most people are going to fall somewhere within this purple area, whereas the line here is the average. And so you can see as you go to every other week, you get more up and down and more white space here. So more time that you're going to be either higher or lower. And then that really starts to fluctuate as you get to every 4-week dosing. And so it may be that somebody that's on every 4-week dosing may have a bleed kind of as they hit their trough here, and then and so if that's the case, you could always back down and go to more frequent dosing. So most people with emicizumab do very well. The average bleeding rate was quite low in all of the Haven trials, and so bleeding is not as frequent, very much like very good prophylaxis with factor, but bleeding does occur. And to treat that bleeding, you're going to need something other than emicizumab. So you can't use emicizumab for treatment for bleeding, even if you're using it for prophylaxis. And we'll talk about that in a little while. However, there was some data from the Haven trials that minor bleeding events, epistaxis or maybe even very early joint bleeds may resolve on their own without factor treatment. This was presented at one of our scientific meetings. It hasn't been published yet. I'll be interested to see, once they analyze it across all the Haven studies, how that worked out, what bleeds were able to resolve on their own. However, if it's more severe bleed, a more significant hemarthrosis, a muscle bleed, something like that, you're going to need products other than emicizumab. And so if you don't have an inhibitor, that would be factor VIII. If you have an inhibitor, then you would have to consider one of the bypassing agents. So why can't you treat bleeding with emicizumab? Why can't you give an extra dose? Well, I kind of showed you that curve earlier about the levels with emicizumab, and so the levels don't increase, very fast after you give a dose. It's kind of one of the downfalls of giving subcutaneous as opposed to IV dosing. But this graph also kind of explains it, and you don't have to worry too much about what all of this means. But if you just think about the blue line as how well emicizumab is working, you can see that up to a point it's going up, and then it plateaus, and then it goes back down. And that's because at some point you are, instead of pulling 9 and 10 together, you have so much emicizumab there that you're actually pulling them apart. So you may have one molecule of emicizumab bound to 9 and one molecule of emicizumab bound to 10, and they're actually separating them instead of bringing them together. And so that's another reason that you can't get too far up this curve. Now, the target range that we're targeting is down in this area, so that we're not close to kind of maxing it out in most people. So you don't have to really worry about this in day-to-day use of emicizumab. Now, the other kind of concern that when I talk to people about emicizumab, they always want to talk about, okay, what happened with the blood clots during the trials. And so just to, these were all during the Haven 1 and 2 trials. And I believe that correct. They were actually all during the Haven 1 trial. I misspoke there. And this was in people with inhibitors who were using FIBA, which is also known as a prothrombin complex concentrate, for bleeding episodes. And not only were they using FIBA, they were using a lot of FIBA. So they were using over 100 units per kilo every 24 hours. Sometimes they were using multiple doses of FIBA in the same 24-hour period. And so this led to problems with blood clots, or you can see here, this is called thrombotic microangiopathy. That's a really fancy word. That means that you get tiny little blood clots in your small vessels that causes problems, sometimes with your kidneys, sometimes with your intestinal tract. But these were only associated with high doses of FIBA. They found that if you used lower doses of FIBA or Novo-7 for bleeding, then this wasn't as significant concern. So what about the treatment of inhibitor patients? And this is just what I told you. If you give very high dose FIBA, then you have to worry about blood clots. However, the data, and we have a lot of data now, that standard dosing of factor VII is safe in people on emicizumab. And in fact, you don't necessarily even need as much or as high of a dose as we used to use in people that weren't on emicizumab. You may get away with 1 dose instead of 3 doses, or you may only need a couple of days. For example, surgery, sometimes we only treat before and maybe once after, depending on the surgery. Sometimes you have to treat more than that if it's a more severe surgery, but you don't need as much factor VIIa as you used to. And I just saw this typo here. I apologize for that. There was one reported case of a heart attack after 7A in a patient on emicizumab, and that was reported in 2019. However, this patient had other health issues, so it's hard to really know if this was because of emicizumab or just because this patient would have just had a heart attack anyway. And this is the only episode of thrombosis I can find in somebody on emicizumab with just 7A. And so the National Hemophilia Foundation releases guidelines for treatment for people with hemophilia. And they say in people with inhibitors that we should manage bleeding with Novo-7 or 7A. There's actually another 7A product now, so I shouldn't just say Novo-7, at a dose of 90 to 120 micrograms per kilo as an initial dose. And most of the bleed should be able to control with 1 to 3 doses. And they say that you shouldn't ever give it more than every 2 hours. I can tell you that we typically haven't been needing this many doses of Novo-7, 3 doses every 2 hours. And so, and then in people who don't have an inhibitor, factor VIII is still the gold standard for treatment of bleeding, even if you're on emicizumab. And so you might say, well, wait a minute, that emicizumab is hugging up the factor at 9 and 10, and so how's factor VIII going to get in there if emicizumab's already there? Well, factor VIII is so much better at its job than emicizumab that it can go in there and just bumps the emicizumab out of the way. And so when that happens, then you have you have the factor VIII that goes in there and just supersedes the emicizumab. And so you might say, well, wait a minute. Well, then you have factor VIII doing its job here, and then over here you have factor VIII doing its job here, and emicizumab doing its job over here. And so that may cause problems together and maybe additively cause a problem with blood clotting. However, that doesn't appear to be the case. And that's because, again, factor VIII is so much better than emicizumab. It's almost like emicizumab isn't there if you have factor VIII. And so it doesn't additively increase the clotting factor potential. Factor VIII does its job, and then once it's away, emicizumab kind of returns to kind of its prophylactic role. And so the current recommendations is to use factor VIII as standard of care. And again, the National Hemophilia Foundation MASAC committee says that we should essentially use the same dosing as patients who are not on emicizumab. Now, I find that I often don't need as many doses of factor VIII for people on emicizumab compared to people who are not. But again, this is kind of depending on the severity of bleed and the site. You may need more factor VIII, or you may get multiple doses. And so one other thought about emicizumab before we leave, and this is again a guideline from the National Hemophilia Foundation, is that emicizumab is given subcutaneously like insulin, and so you don't have to have a central line, you don't have to have a port, if you wanted to think about prophylaxis in young children. And so they say that we should be talking to our patients about babies, and so we've never been in a position where we could start somebody who's 1 week old on prophylaxis to prevent the worst complications of hemophilia, the bleeding into the brain. And so now it's our practice at Cincinnati, as well as at probably many of your institutions, to talk about emicizumab with parents of new children with hemophilia. And we've started, we've considered starting it on infants that are born that haven't had prior exposure. And so the current trials for emicizumab and all of these current clinical trials that I'm going to show you are available on clinicaltrials.gov, and you can go on there and see what the trial is doing and where it's open and if it's currently enrolling patients. And so, and like I said, that's clinicaltrials.gov. Actually, I don't have it on this one, but I'll have the website on other slides. And so, excuse me, currently they have Haven 6, which is looking at emicizumab prophylaxis in people with either mild or moderate hemophilia A, or Haven 7, which is to look at emicizumab in that group that I was just talking about from birth to 1 year of age. The group that we used to just kind of watch, mostly without prophylaxis until they were starting to kind of cruise or starting to walk, starting with lower numbers of prophylaxis as their veins permitted. So there is another clinical study. Novo Nordisk has also generated a bispecific antibody that's similar to emicizumab. It's called, they don't have a fancy name for it yet, it's just called MEM8, in people with hemophilia A, and their studies, which are all named after, like, it brings to mind scouting to me, but Frontier is the name of this study, Frontier 1, and there are other Frontier studies that are currently planned. So that brings us to the end of non-factor therapies, and You know, we've been through emicizumab now, and you know that's kind of familiar. Now we're going to move into things that are maybe a little less familiar, and fitusiran is the next one. And it's kind of a funny name, and it doesn't really tell you what it does. It's kind of like emicizumab. It doesn't give you an idea of where it's targeting. And so I promise I'm not going to get too deep into blood clotting. And even when I talk to physicians, they always roll their eyes when I put this clotting cascade up there. And I was trying to figure out a way to describe how fitusiran and anti-TFPI antibodies work without showing you this pathway, and it just doesn't work. And so you don't have to worry too much about all of these numbers. But remember that this is where hemophilia is. And so really what happens is blood clotting goes through this pathway, and then it becomes further activated through this pathway. So it starts here, and then feedback amplification, or it gets going more and more through this pathway. And so for people who have inhibitors, this is taken off the table. This feedback kind of amplification or increased clotting feedback is just off the table. And so the way we've worked on trying to get more blood clotting is through this initiation pathway, right? Through and you know, I've mentioned 7A before. You know, if you put more and more 7A in there, you can drive blood clotting through here without needing factor 8 or factor 9. It's the same way FIBO works. You get a bunch of activation of these proteins, and you give it, and you get more blood clotting compared to, you know, if you don't, since you don't have these proteins. Now, fitusiran targets a protein called antithrombin 3. And AT3 is an easy name for it. You don't have to remember the fancy name here, antithrombin 3. But AT3 is an inhibitor of blood clotting. So it means it blocks, it puts the brakes on blood clots. And it does this through multiple clotting factors, but the ones it works best with are factor 9 factor 10 and thrombin. And so if you take away this inhibitor, if you take the brakes off clotting, you unleash it. And so you get more blood clotting if you don't have AT3 compared to if you do have AT3. And this is independent of factors 8 and 9. So whereas emicizumab was only for hemophilia A, if this fitusiran targeting antithrombin 3 is for hemophilia A and B. However, this kind of taking the brakes off has risks. We know that people that have low antithrombin levels are at risk for blood clots. And so the hope is that you know, you're taking antithrombin away, but without having factor 8 or factor 9, it kind of rebalances the scales. And so that instead of, you know, having antithrombin 3 deficiency and being at risk for blood clots, with having both of them, you're kind of rebalancing the scales. And again, coming back to this pathway, this is where antithrombin is working, or AT3 is working. And remember, I'm sorry, I thought I had the boxed in here. This is where hemophilia is. So this is all, you know, we're trying to get increased blood clotting through this pathway here. So again, you don't really have to pay attention to the numbers here, but if you look at the graphs, and this is a graph of blood clotting potential, and so the black line here is people without hemophilia, and you can see they have a really nice increase and you know, what we call area under the curve, or you know, a lot of blood clotting potential. And you can see here, going from gray up to blue, in people with severe hemophilia A, this is really bad with 100% antithrombin, but as you get rid of antithrombin, blood clotting potential gets better. And it's the same way with hemophilia B. If you're down here with the gray with all of your antithrombin, it's very low. But as you go down to 10% or even 0, your blood clotting potential is getting more normal. I would say normal in quotes, because you can see it's still not getting back to somebody without hemophilia. So indeed, there was this drug called fitusiran, or there is a drug called fitusiran that was able to target antithrombin 3, and this was presented again in the New England Journal of Medicine, a very prestigious article or journal for clinical research. And what they were able to show is this fitusiran was able to generate low levels of antithrombin 3 and actually do it for quite a while. You can see the doses here were given at these black arrows, and so every 30 days you get 1, 2, 3 doses. So at 60 days, you're at your kind of at lowest, but these levels kind of held down for quite a while. Out more than a month or 2 even after the last dose, and then only gradually responded when go back to normal. So this is something that then again, like emicizumab, may not have to be given very frequently and can be given subcutaneously. And this is another way to look at that first graph I showed you. This is blood clotting potential. So the higher you are, the more blood clotting potential you have. And so you can see that people with hemophilia, if their antithrombin level is high here, their blood clotting potential is low. But as they were able to suppress their antithrombin levels, their blood clotting potential went up. And the blood clotting potential of these people over here, both in hemophilia A and hemophilia B, was almost like a lot of the normal controls. So, the proof of principle, or the rationale for all of this appears to be sound, that you can increase your blood clotting potential by lowering antithrombin 3 levels. And they went through a phase 1 study, and phase 1 studies are primarily focused on safety. Phase 2 studies are focused on how well the drug works. And it was during the extension of a phase 2 study that a patient in Eastern Europe developed a bleed while on fitusiran, and it was a bleed in the head or in the brain. And they were treating this as if it was a primary bleeding event and giving the patient lots of factor. And unfortunately, the patient died. After the patient died, they sent the records to the company that was conducting the trial, and they reviewed it, and they said, wait a minute, this wasn't a standard bleed. This was actually caused by a blood clot in one of the veins in the brain. And so instead of trying to making it better with a bleeding with lots of factor VIII, may have actually been making it worse. And so the fitusiran studies were paused. They kind of did the same thing that they did with the emicizumab studies. They rethought things, thought about how they're going to treat bleeding episodes, and were able to restart the program. The phase 3 study was underway, and then in 2020, in I think it was October of 2020, again, they paused the studies because there had been some blood clots. And in this situation, there's not a lot of data out there. So unfortunately, I don't know the details, and so I can't share them with you. But they were able to meet with the FDA, review all the data, review their changes, and the FDA approved moving on with the study. So this is in current clinical study in the United States. I am not sure about studies outside the United States. I believe they were looking to try to get those restarted as well, if they have not already restarted them. And so the current fitusiran studies are they're called the Atlas studies, and one is prophylaxis in adults with hemophilia A or B, and hemophilia A or B with or without inhibitors. And Atlas Peds, which is less than 12 years of age, again, with or without inhibitors. And then an open label extension study, which just allows you to continue the product after the study is completed. So that was fitusiran and antithrombin 3. Now we're going to talk about a different inhibitor of coagulation, and one that's been a little harder, it seems, to kind of get into, or at least get a product into the space. It's called anti-TFPI antibodies, or tissue factor pathway inhibitor. And again, you don't need to memorize this name. As long as you know TFPI, that's more than enough. But I'm coming back to this cascade again because, remember, we can't generate any blood clotting on this side of the diagram. So we have to try to if you have an inhibitor to either 8 or 9, you can't get anything through here. So you have to drive blood clotting through this pathway. And so how else might you do that? So I already told you, for example, factor 7A here, FIBA at multiple points, fitusiran or antithrombin 3 targets here and here. So now tissue factor pathway inhibitor is a way to, this protein blocks this pathway right here. And so the idea is that if you take this break off of blood clotting, that again, you can get increased blood clotting and you have better ability to control bleeding or to stop bleeding or prevent bleeding. So there's been several attempts at getting a molecule into this space. The very earliest was by Baxter. Many of you know Baxter is the company that was then became Baxalta, and then was bought by Shire, and then was bought by Takeda. And so now it's Takeda. But this was a compound that was made during the days that it was still Baxter. And so it targeted TFPI, but it didn't do a very good job of blocking its activity. And what it did instead was made it live longer. And so you had increased levels of TFPI that was not blocked. And so they actually saw bleeding with regards to that compound. Another one that was under investigation by Bayer was discontinued due to blood clots. The one that's probably the farthest along in clinical studies is concizumab. Excuse me. This is made by Novo Nordisk. At one point in time, the study had been also paused due to blood clots, just like fitusiran and emicizumab had problems. However, again, after they kind of retooled the protocol and made some changes to allow safety, then they were allowed to restart. And then another compound made by Pfizer called marstacimab is a similar product. So both of these are antibodies that target that protein called TFPI. So again, this is blood clotting potential, and the higher the level, the better the blood clotting potential. And you can see that as you increase the dose of concizumab, you get higher blood clotting potential in people with hemophilia. And I believe this is hemophilia A, this is hemophilia B. So, these look very similar to each other. And then if you look at, again, this is just another way to look at this. This is how much of the TFPI is bound to the antibody. So if it's low, less than 50%, you don't have very much blood clotting potential. But as you increase the amount bound to the antibody, you have better blood clotting potential. Also, as you give this drug, you see evidence of activation of blood clotting. So this is called a D-dimer, and this is a prothrombin fragment, but both of them just show evidence that blood clotting is happening. And so that just kind of twinges our antenna as hematologists, saying, okay, well, we know that something's going on here. We have to be careful. It doesn't mean that it's bad or that you can't use it, but it just means that you have to be careful. And so you can see this was with the higher doses that you get these higher levels of blood clotting activation. It's the same with marstacimab. So the Pfizer product, you get increased blood clotting potential as you give increased doses of the product, and then but you also see evidence of blood clotting activation. So essentially, these antibodies look very similar to each other, right? And so concizumab now has had some studies in humans, and they were able to show that compared to treatment with 7A, that concizumab does significantly lower the bleeding rate. Either all bleeds spontaneous bleeds, or joint bleeds. And you know, they were able to show this in hemophilia A with inhibitors, or hemophilia B with inhibitors. And I think hemophilia B with inhibitors, it's kind of an overlooked population. You know, it's not very common, but you know, it's a situation where it's difficult to tolerize people, and there haven't been a lot of products available for them. So current anti-TFPI studies, concizumab. Remember, this is Novo Nordisk. They're the folks that name their products that sounds like scouting programs. So they have Explorer 7 and Explorer 8, which is looking at the efficacy and safety, or how well does it work and how safe is it, of concizumab in patients with hemophilia A or B with inhibitors, and hemophilia A or B without inhibitors. And then the Pfizer product, marstacimab, excuse me, and my apologies to Pfizer, by the way, if I'm butchering that name. But this is a study in adolescents and adult severe patients, hemophilia A or B, with or without inhibitors. Okay, so that was the really unusual part. Now for the even maybe more unusual part, the potential cure. You know, this is something that we've been, as I said, been talking about for ages, and that we've been really pursuing. And I know all of my patients are, you know, they never ask me about fitusiran. They never ask me about these TFPI antibodies. They always say, hey doc, what's going on with gene therapy? And so, you know, for a while there, I was saying, oh, I think it's going to be a while. And then, you know, I was, you know, over the last year, I was saying, well, I think, you know, actually, I think I was wrong. We may have a product pretty soon. And as it turns out, I was right initially. It may be a while before we have a licensed product. Hopefully for hemophilia B, we're a little bit closer than we are for hemophilia A. But, you know, hopefully we'll have a product out there before too long. And so I just want to kind of go into what we're talking about when we think about gene therapy. And so when we talk about gene therapy, it's introduction of a gene. So a gene is a full set of instructions on how to make a protein into an organism to facilitate production of that protein. And so it can be any, you know, it can be any protein. You know, we think about hemophilia as a prime example of a single genetic disorder that you know, you can just have one gene product that can change the outcome. You know, another one is sickle cell disease, and sickle cell disease is also heavily invested in finding a gene therapy that will cure that. And so there's many ways to introduce a gene into the cell of an organism, depending on the type of cell, the type of organism. You know, if you're inserting it into a living animal or human, versus, you know, a plant. And so viral vectors, chemical agents, or even mechanical methods, you know, to insert genes into plants, they actually use something that looks kind of like a shotgun, just to shoot it in with little metal pellets. But, you know, for animals and for humans, the primary method that has been utilized are some form of virus vector. And we'll get into more about that. So a lot of times I might say virus, or I might say viral vector. And so what is a viral vector? And so essentially what we're referring to here is a virus that has been modified in a laboratory. And it's modified such that it no longer carries its own genetic information. It no longer has the instructions for it to replicate or to infect it, or let me rephrase that. It no longer has the ability or the instructions for it to replicate or reproduce itself in a host organism. It has, you know, it has the ability to infect a cell, and then it's kind of done. And vectors can be, these viruses can be administered to either cells in culture, and typically when we do that, it's bone marrow cells. So these are cells that are in the laboratory. So we take, for example, bone marrow cells out of a sickle cell patient, they treat it with a viral vector, and then they reinfuse it into a person. So the type of therapy or the type of disease really dictates what type of virus you need. So there's some challenges with this. First of all, the vector has to home into the right cell type to infect it. So if you're wanting to have a gene that goes to the liver and you choose a virus that primarily infects the lung, it's not a good viral vector. So you kind of have to choose the right type of virus to do that. Additionally, vectors, viruses can only hold so much, and so and some of our genes are larger than other genes. The vector has to be efficient at transferring the gene to the cell, and so when we think about the correct gene, we think about the instructions to make it, but that has to include instructions on how much to make, and the correct, we call it a promoter, something that promotes gene production both in the correct cell that's being infected and at the right level. And so just a schematic showing you a virus, that's carrying this engineered DNA molecule with the new gene in it, and it infects the cell, and as it's going in and being released into the cell, it then releases its cargo, which is the gene that we want, into the cell, and then that DNA then is able to go on to make new protein in the cell. So where does the gene go? So there's different types of ways that the DNA from gene therapy is used in the cells. So some are called incorporating viruses, and as the name sounds, the cargo that they're carrying is incorporated into the genetic information of that cell. And so the chromosome, which is the basic, one of the main blueprints of the genetic information for the cell, it incorporates that gene into the chromosome of the cell, and it's a permanent change. And so every time that cell divides, both of its daughter cells will have that new DNA. Other viruses are non-incorporating, and the viruses that typically are used in hemophilia are non-incorporating viruses. And so that DNA is inserted into the cell, but it doesn't go into the chromosome. It hangs out, and it hangs out outside of the chromosome. And so the concern is that then this genetic information may be lost. So there are pros and cons. And here, the pro is that it's permanent, but the con is that it may go somewhere that you don't want. It may interrupt an important gene, or it may interrupt a gene that causes problems for the cell. These have a low likelihood of those kind of issues of inserting into the main genetic part of the cell. But at the same time, it may not be as long-lived. As the cell ages, it may be lost, or as the cell divides, likely only one of the progeny, one of the daughter cells, is only going to get that information, if that. And so, the concern is that as these cells divide, you lose the genetic information. And liver cells do divide, even in adults. The other thing to remember is, because these are viruses, our immune system is highly adapted, and it's very good at responding to infection. And so, unfortunately, most of these viruses are based off of something that's in the wild, that's out there, that we've seen. And so, these viruses are something that typically infects humans. And so, therefore, we may have pre-existing immunity. And if you have pre-existing immunity to a viral vector, that may determine that you're not able to get it, because you would just clear that viral vector instead of actually having benefit from it. But even in people that haven't seen it before, the immune system may react to gene therapy as if it's being invaded by the virus. And so not only does the immune system clear out typically a virus, but it also often kills the cells that have been infected by the virus. And so we saw this in some of the hemophilia gene therapy studies, that early on they had nice production of factor VIII or factor IX, and then as a couple weeks went on, or a month or two, and then it started falling off, and then eventually went away. And so what's happening there is the immune system is just saying, wait a minute, those cells have foreign DNA, foreign protein in them, and we need to get rid of them. So this is a timeline of gene therapy, and going back almost 100 years. And when they first realized that a gene could be transferred, and this is a gene being transferred before they even knew that DNA was the genetic material. They could see that traits were transferred between bacteria. And so, they were able to do things in the lab to figure out that, how can you cause a gene mutation? Viruses can cause gene mutations. There were some early attempts at gene therapy that were kind of very naive when looked back through the lens of 2021, but at the time were state of the art, right? The first time that it was, there were several attempts here at human gene therapy, especially this one was somewhat dubious. But then the first gene therapy trial here in a severe immunodeficiency called severe combined immunodeficiency was started. Unfortunately, there was a death in 1999, and this was related again to the idea that we're giving a virus that triggers the immune system. So if you give just lots and lots of virus, you can trigger a horrible immune reaction, and that's what happened there. The first hemophilia gene therapy trial was in 2000. Unfortunately, was not successful, but they were in early with gene therapy trials. I believe this was Dr. Hai's group. And then, unfortunately, this was the incident in 2002 that really kind of set us back with regards to gene therapy. And there was some cases of leukemia in one of the severe combined immunodeficiency gene trials. And so they had to take a step back and figure out why that happened. And what happens is one of the genes was inserting in a place that it shouldn't, and it was causing those cells to grow uncontrollably and essentially form a leukemia. But thankfully, they figured that out, and many scientists who are smarter than I were able to figure out then, okay, well, how do we prevent this from happening? And they're able to safely now insert genes into cells without worrying about causing cancer. This culminated in the first successful hemophilia B gene therapy study in 2009. This was followed several years later by the first successful gene therapy trial in 2015. And then in 2017, the first approved gene therapy by the FDA. I will say this is not hemophilia, so we don't have an approved. As I looked today, just to make sure nothing had been approved that for some reason I had missed, but we have nothing has been approved for hemophilia and for gene therapy. So this was kind of one of the groups that changed thinking and saying, okay, well, we can really do this. This was in hemophilia B out of the University College of London. And they're using a virus here called adeno-associated virus. And this is almost every single one of the hemophilia gene therapy trials now are using this virus. And so what is AAV, or adeno-associated virus? So this is a virus that is out there in the world. Many of us have had it and never knew it because it doesn't cause a disease. It comes in, it replicates, it infects us, we develop immunity, and it goes away, and we never know we had it. We are increasingly realizing the prevalence of this virus and seeing that a lot more people are immune to it than I think was realized in the past. However, AAV is kind of seems tailor-made for viral treatments or gene therapy because it cannot reproduce on its own. Even the kind that's out there in the world, it has to have another virus that infects somebody at the same time to allow that virus to be able to successfully infect somebody. And so it requires adenovirus, which is why it's called adeno-associated virus, for reproduction. And remember now, they're going to take this virus and kind of rip all its guts out and then insert the gene that they want to carry. And remember, and the other thing about AAV is that it is somewhat limited in the size of the load that it can carry. You know, it can only carry a certain size of a gene. You know, and then you might ask, well, why was factor IX first? Well, this is the size of the factor IX gene versus the size of the factor VIII gene. And, you know, it's almost 6-fold larger. And so just getting things packaged in there, you know, it was easier with factor IX. And so you can learn how to do it with factor IX and then move on to factor VIII. But it didn't take that long. I remember, you know, telling my patients, you know, they were hearing about the hemophilia B study and saying, how long is it going to be for hemophilia A? And I said, well, I don't know. It probably will be longer. And it came around before I you know, personally thought it would happen. And this was the first successful factor VIII gene therapy study in hemophilia A. This was by a company called BioMarin. And you can see they got levels that are not only normal in some patients, but they got levels that were way above normal in some patients. And so, you know, they were able to get people to fully correct. And this is what we call a phase 1 study. So it's a very limited number of people. You can see that here it was 7 people that were analyzed in each of these time frames. You know, essentially it's demonstrating that it's safe and that there is some evidence that it works. So based on this, they went on to a phase 3 study, and these phase 3 studies are like I said before, they're the ones that really help, that allow licensure of a product. And this hasn't been published yet, but it is available on the BioMarin website, you know, and this is the site used, and I just accessed this today to confirm that it's still up. And by the way, today, I'm pre-recording this, today is March 18th. So if you look on the day of SpringFest and this isn't there, I apologize. It was there on March 18th. But anyway, these were the first 17 patients enrolled, and you can see that they got fairly good levels. Not quite as high as in that phase 1 study, but there were some patients that were quite high. They had 112 patients total analyzed. And the middle value, you know, with a certain number, how many people above and how many people below, the middle value for factor VIII level in those patients was 38% at 6 months. But it was a little lower at 52 weeks or at a year, so it was at 24%. And because it had declined, the FDA said, not so fast. I'm going to make you go back and watch these guys a little bit longer and see if the factor VIII expression stays. And so, you know, so we're still waiting to see, you know, how this plays out and if BioMarin will be the first product approved for hemophilia A. So currently there are 3 clinical trials registered at clinicaltrial.gov in phase 3 for hemophilia A. The BioMarin data that I just showed you, Spark, which was bought by Roche, and then a partnership between Pfizer and Sangamo. And then 2 phase 3 trials for hemophilia B, one by Unicure, which is actually had just recently was paused due to a safety concern. I think they're going to be all right there. You know, this was in a patient with hemophilia, or excuse me, that had hepatitis C, and so I don't think that the problem was because of the virus, but you know, we'll have to see again also how that plays out. And then a partnership between Pfizer and Spark on a hemophilia B product. So that brings me to the end of this talk, and I'll be joining you live in just a few seconds to take any questions. So thank you very much, and thank you for paying attention.
Thanks, Dr. Mullins. We do have one question, and I think it's coming up on the screen here directly. There we go. So please feel free to ask more questions in the comment chat section. So, Dr. Mullins, do any of these drugs have potential to treat Glanzmann's thrombasthenia?
That's a really good question. And Glanzmann's is, for those of you that aren't familiar with it, is a platelet disorder. And it's a very severe abnormality of platelet function. And it leads to essentially an inability of platelets to form a plug. And we think of a blood clot as the clotting, cascade that I've shown you many times during this talk today. But platelets are a very important part of that as well, and really facilitate the clot formation and form an initial plug that then is supported by the clotting process and the formation of what's called fibrin clot around it. And so, unfortunately, there haven't been a lot of products to treat Glanzmann's thrombasthenia bleeding other than platelet transfusion. Now, Novo Nordisk's drug Novo-7 has been approved for treatment of bleeding in Glanzmann's, and I think certainly there was data showing that is effective. I think some patients probably benefit from that more than others. With our cohort of Glanzmann's that I've seen at Cincinnati Children's, I haven't had a lot of success treating bleeding, especially more significant bleeding with Novo-7. So there really is a group of people that are really asking, hey, what drugs can we use that are for prophylaxis? And they're asking, IV, subcutaneous. It's not whatever drugs that are available can we get those for prophylaxis? And nobody yet is planning, as I've understood, about testing either fitusiran or the anti-TFPI antibodies for use in Glanzmann's. I think it would be a prime situation for a clinical trial, and hopefully the companies may either be interested in do that, or if not, maybe an investigator-initiated trial. The real limiting problem with that is the numbers of people with Glanzmann's thrombasthenia. We have, for example, here in Cincinnati, one patient, and we get referrals pretty frequently because they come here for assessment for bone marrow transplant, which is curative if you have a donor. But it's just not a very common disorder. So getting the number of patients to do a trial in Glanzmann's, it can be difficult. You have to have a lot of centers to do it. I think you're muted.
I was told to mute and then I forgot to take it off. Has gene therapy seen more setbacks or more promise overall? And that's related to the general idea or specifically to hemophilia?
Well, there's been a lot of setbacks. There's no doubt about it. I think, it still has a lot of promise. And, there's, even if, it takes a while to get any particular technology perfected. And so right now we've seen all the setbacks and not maybe as many of the successes as we would like. But this is something that I am confident will happen in the future. It's just, it may not look like our current gene therapy. If you go 20 years down the line, it may not be AAV8 that we're using to introduce a gene. There are new technologies that I didn't get into that actually allows you to correct a gene. And so there may be, it may be that it's not exactly the 2021 technology isn't the ultimate technology. It's certainly the best we have right now. But there's a lot of opportunity out there. And there are trials looking at various options for how to do this other than just the AAV. There's two groups that are looking at producing factor VIII in platelets, and then that's exciting because then patients with inhibitors might be able to have gene therapy and be treated that way because their factor VIII would be protected in the platelet. And so I still think there's a lot more promise out there than setbacks. And even though I think we tend to get discouraged because that's what we've seen, I think there's still a lot of hope out there, and not just for hemophilia. I mean, those of us who treat sickle cell disease, are really encouraged by the progress in the gene therapy in that disorder as well. And so, between the two, I hope that in 20 years that I'm not treating severe hemophilia anymore. That'll make my retirement a lot more comfortable, because then I won't have to worry about my patients. Hopefully, everybody's converted to either mild or normal.
Thank you. I have two more questions. Ashley says thank you. I know you're no fortune teller, but do you think that Emicizumab may be on the market within the next 5 years? I know it's been in process for a very long time. Do you think it's 5 years down the line, 10 years down the line?
It's always hard to project when something. Emicizumab hasn't started its phase 3 study yet, so it's finished. They're in the process of finishing phase 1 and moving to phase 3. They're setting up sites for phase 3, but it hasn't begun yet. So it usually takes at least a year and a half for the trial to be finished and then submitted to the FDA. And so, I mean, with everything being perfect, no delays, no whatever, then I think 3 years maybe. But it's hard to know for sure.
Thank you. And we have one last question from Megan. What, if any, impact do you think that Emicizumab treatment has on the baseline tendency to clot? Because at baseline, a patient without hemophilia A doesn't necessarily have much, if any, factor VIII floating around. Is this regulated mostly by the amount of other activated clottings?
That's a really good question, and it was my biggest concern about Emicizumab as it was being introduced and going into clinical use, especially with using extra factor VIII to treat bleeding. And so essentially Emicizumab is like a limited activated factor VIII, so you always have a little bit of clotting potential going around. But what appears to be the case is that you have to have that 9 being generated, that activation of 9, before you get any activity from the Emicizumab. If your 9 is not activated, then you're not going to activate 10, even if Emicizumab is bound to both of them. So it appears to be regulated in that way, and the other regulation steps of hemostasis are able to control that and allow it to be safely give you this baseline clotting potential, but not necessarily have clotting going on all the time. And so that appears to be the regulation there. And I will say, as I mentioned in the talk, addition of factor VIII on top of Emicizumab, it only looks at the amount of factor VIII you have there, not the Emicizumab. So while you have factor VIII there, it's always going to supersede the Emicizumab.
Thank you. That was very helpful. And inquiring minds want to know, what barbecues are your favorites?
I love the North Carolina style chopped pork barbecue with the vinegary sauces, and the Memphis dry rub ribs. Those are my favorite too. I just don't get into the Texas sausage links and beef brisket, but I may get into trouble. People may post comments saying that I'm the devil for hating brisket.
Well, thank you so much for this interesting update, and your fortune telling as well. So thanks again. And lastly, I want to let everybody know that we're now moving to hear some more information and video